Thank you for inviting me to speak on these topics, personalized medicine in epilepsy in resource-limited countries. One treatment does not fit all. And in this picture, the big tablets does not fit to the little man on the right side. Just like carbamazepine is not suitable for all patients with focal epilepsy, and it doesn't mean sodium valproate may not work in people with focal epilepsy as well. In our current practice, we use one treatment for all, and then we decide who are the patients who have seizure freedom more than 50% and who doesn't have, and who develop side effect and who doesn't. But in future medicines, we would prefer to have more personalized approach. The approach include the investigations profile, the characterizations of the clinical pictures, as well as the determinations of treatment according to these factors. And we hope that to subdivide the patients with similar diseases into different groups, which different treatments may fit best in different groups. But how is it possible, especially in our resource-limited setting? In fact, we were questioning ourselves whether we have the test, especially the genetic testings in our country, whether the facilities are available, whether the expertise, the treatments are all available or even affordable. There are always these 5 A's that block us from implement the personalized medicines, which include the accessibility, especially the tests and facilities, the affordability of the treatments, the genetic testing, the acceptability of the clinicians as well as the patients, the accommodations to use these facilities, and the availability of those in our country. And therefore, we always thought personalized treatments is too far for us. It's beyond our reach. However, we can come to some simple rules which I used often in the past. Rule number 1, find the evidence. In this study, the class 1 studies was selected in associated with various seizure types. And for example, adults with partial onset seizure, or now we call focal onset seizure, there are 4 class 1 studies with level A evidence, which include carbamazepine, levetiracetam, phenytoin, and zonisamide. Whereas for children with absence, as we can see on the 3rd row, there is only 1 study with class 1 and level A evidence using etosasamide and sodium valproate. Rule number 2 will be according to the seizure types. Certain medications has broad spectrum of mechanisms, for example, sodium valproate or lamotrigine, and sometimes topiramate. And that's why we use this treatment more often in those with generalized epilepsy, especially those with absence and myoclonic seizures. We know that carbamazepine or phenytoin, which are sodium channel blockers, are not suitable in these patients because they may aggravate myoclonic seizures or even absence seizures. Rule number 3 is to follow the guidelines. This is the guidelines by Malaysian Society of Neuroscience, which was published in 2017. And here we follow the monotherapy in the first column. For example, in focal seizure, we recommend carbamazepine, lamotrigine, or levetiracetam, and in some patients we use oxcarbazepine, sodium valproate, or zonisamide. Whereas if we look at the lower end for myoclonic seizure, we prefer or recommend sodium valproate, levetiracetam, or topiramate. Rule number 4, to keep it simple. In general, for patients with generalized epilepsy or seizures, we recommend sodium valproate unless they are contraindicated. For example, in women with childbearing age, then we can use lamotrigine, levetiracetam. For focal epilepsy, our first choice is still carbamazepine. Sometimes in certain places we use phenytoin. However, in certain subgroups, we may consider lamotrigine, levetiracetam, and zonisamide accordingly. But to be more specific, there are other areas of personalized medicine in epilepsy, which include the diagnostic of various seizure types or epilepsy syndrome, the predictions of outcome or seizure in various conditions like brain tumor or traumatic brain injury, the preventions of certain adverse events like in the Steven Johnson in carbamazepine using HLA-B1502 screening, drugs, especially the selection of drugs for certain subgroup of patients with various types of seizure and comorbidities, as well as prediction of surgery outcome and complications after surgery in those with resistant epilepsy. And the last one is on relapse, on the likelihood of seizure freedom or relapse in various subgroup of patients, especially those who have achieved remissions. So this is the first tool we have developed. This is a simple and rapid tools for resource limited setting, and it can be applied by patients or eyewitness. On the left, you can see the questions that the patients can answer accordingly, which include aura, unilateral motor phenomena, or oral automatisms. And the questions are written in the form where patients can understand. On the middle, we can see the summary or specific points for clinicians and the score at the end. And this simple and rapid tools is useful for patients or for clinicians to decide whether it is likely to be focal seizure or not. And those with score more than two or more has 85% specificity to be focal seizures. There are also other online tools like EpiPix. And this online EpiPix tool is useful to select appropriate anti-seizure medications in patients with epilepsy, and this is published in year 2020. You can click on this link to use the online tool or just type EpiPix in Google search to look for this. This is the website for EpiPix. For example, if your patient's got epileptic seizure or temporary episodes with altered consciousness, then you can click accordingly and click next steps. And let's say your patient is 20 years old, a female, and with lip smacking or staring without any changes in the MRI, or you are unsure. Sometimes you can consider other choices, for example, irregular jerks for myoclonic seizure, bilateral stiffening and shaking within 1 hour awakening for generalized tonic-clonic seizure in early morning. And sometimes there are symptoms to suggest non-epileptic event, for example, syncope, like pale predictably, loss of consciousness with urinations and defecations. And when you choose this, then the answer will be more likely to be non-epileptic seizure. And then you click next steps. And because of the staring and absence oral automatism, then you think the patient is likely having focal seizure, and you click next steps. It will show whether your classifications is matching the classifications based on the algorithm. And let's say you think that the patients may have absence because of blank staring, but you are unsure about the lip smacking, and you click next steps. Then they will appear a different classifications by your decisions as well as based on the algorithm. Sometimes if you think that the algorithm is correct, you can proceed with classification suggested by the algorithm. And then you can choose the comorbidities. For example, let's say this young lady has type 1 diabetes. And then you can click next steps. And you will realize that carbamazepine and phenytoin are not in the best choice or in group A because the enzyme inducing effect of this may interfere the diabetic medications. The next personalized treatments is related to HLA screening in predicting the drugs-induced cutaneous adverse event. As we know, carbamazepine was related to HLA-B1502 and it was first published in Taiwan. Subsequently, we have reported a similar associations in Malaysia. And beside 1502, we also have reported A3101 in related to carbamazepine-induced Stevens-Johnson's and toxic epidermal necrolysis. These HLA3101 are not only found in Malaysia, especially the Indians, but also commonly reported in among the Caucasians, Japanese, Koreans, and Han Chinese. We also reported similar associations in Indonesia as well as Myanmar, and it was subsequently reported in Vietnam and Thailand as well. Besides 1502, we also found 1513, which was associated with phenytoin-induced adverse event. In fact, HLA-B1513 is very common among the Malays, but as well in Javanese and certain groups of population in Indonesia, as high as 20%. And therefore, when we use phenytoin, we must be aware or be careful that the HLA-B1513 may cause or may lead to Stevens-Johnson in these patients. We also found HLA-A2402, which was related to lamotrigine, carbamazepine, and phenytoin in Chinese as well and in other populations. Recently, we have published an artificial intelligence paper to predict the treatment response in newly diagnosed epilepsy. This was recently published in JAMA Neurology in June. And we always thought that artificial intelligence require a lot of complex data entry in order to achieve a good outcome. But in fact, in this study, we only use simple variables, for example, as listed on the right side. There is another tool to predict the feasibility or the appropriateness for an epilepsy surgery evaluations. This is an online tool to help clinicians to decide whether they should refer patients to a more comprehensive epilepsy care services or evaluations or not. You look into these variables, which I will go through one round and to show you how to use the tools later. And these tools will lead to a score that guide you whether you should refer your patients for further evaluations. This is a website on the appropriateness tool for epilepsy surgery evaluations, and you can type epilepsycases.com. If you first launch the tool and select whether the patients have drug-resistant epilepsy or not. And if you answer yes to any of these, you will be asked to refer to a comprehensive epilepsy program regardless of the tool. There will be definitions on the right side to tell you whether the patient has drug-resistant epilepsy or epileptic encephalopathy. And in this case, I'll choose no to the others. and then launch tools. And on the right, it will inform you how the score can be interpreted according to appropriateness of referral. Then you click next. And let's say you are an internal medicine specialist, and next. And if your patient has focal seizure without disconnective features or focal disconnective seizures with bilateral tonic-clonic seizures, then you can click here and choose next. And if let's say patients have seizure more than 1 year, next. And maybe about 10 seizures per year, next. And the seizures are disabling or severe to cause injury or significant impact on the social life, then you click next. And let's say patient has tried 2 medications, and you click next. No side effect, next. And let's say EEG is abnormal and MRI is normal, and next. Then you will have a score of 6 here, which indicates that the system suggests you to strongly consider referring your patients for an epilepsy surgery evaluations. And you can have the patient summary at the bottom, and you can even print the page. Next is a normogram, and sometimes we use this for outcome assessments or predictions of complications. For example, in this case, we use it in temporal lobe surgery. A normogram is a pictorial scale which can be used easily in clinics to predict the outcome. For example, in these patients who had age of seizure onset at 14 years old, which score around 20 points, and the seizure is at the dominant sites, which score 85 points, and the age of surgery is 40 years old, and is a male, as well as having 21 years of education. And when we total all these points together, it will total up to around 150 points. And 150 points is equivalent to about 0.7 risk of naming decline after temporal lobe surgery. And this is very useful for the patients to decide whether they want to proceed or prepare them to encounter naming decline after temporal lobe surgery. However, for personalized medicines, we need to have awareness and practice to put this into practice so that it will benefit the patients and the clinicians in making decisions. So from traditional medical practice to personalized medicine, firstly, we need to empower the patients to make them aware of these tools, to educate the clinicians to use the tools, to add those tools in the clinical guidelines and practice consensus, as well as to recognize the value of using these tools. A lot of times we may think that it will spend more time, and especially in the busy clinic, we may not be able to have time to use these tools. But in fact, in the long run, it will help us to avoid inappropriate treatment or to avoid certain side effect or adverse event of the drugs, as well as to select a best group of patients for epilepsy surgery. And of course, we need to make sure these tools are freely available to be used. Our nephrologist in Malaysia has published a web-based clinical practice guideline, which I found very handy and practical. And in this web page, there are mobile CBG, decisions aid tools, especially the chronic kidney disease risk profile. And this will help the clinicians, especially the GP, to decide what screening tools to use, what assessments to be done, what routine managements to be applied in different situations. In conclusions, personalized medicines may not be costly, and sometimes it's in fact free. There are many areas where personalized medicine can be applied, including the treatment choice, surgical referral, as well as determination of adverse event. Personalized medicine tools can be handy and practical, and is used not only by neurologists or in epilepsy, but in fact by many fields in medicine. And lastly, it will definitely benefit the patients and clinicians in the long run, even though we will need to spend some time in the clinics to utilize these tools. Thank you very much.